name is David Glidden. I'm a professor of biostatistics at the University of California in San Francisco. I'm a biostatistician with an interest in advancing new PrEP products through clinical testing. I'm going to talk about some of the issues raised by the PrEPVacc trial. The PrEPVacc trial is one which uses a pre-randomization incidence for HIV as a control group for later follow-up. This will bring up some very interesting statistical as well as operational issues about how we may be testing new PrEP agents. The PrEPVacc trial includes multiple phases, but the most intriguing of these happens in 2018 when they initiate a registrational cohort during which there will be follow-up for HIV incidence. This is a very innovative study, and what I love about it is it evaluates multiple prevention regimens, and it does so through the use of common control groups. In the case of the vaccine period, the common control group is randomized and concurrent and placebo controlled. But the innovative part is that the PrEP period can be compared where we have two PrEP agents. So again, two agents. The common control would be HIV incidence during the pre-PrEP period, the pre-PrEP randomization period for that study. I want to think about during what kinds of situations this will make sense when it's available and how well it can approximate our gold standards. So I'm going to be focusing here on the idea that we're testing a single PrEP product, but it will apply to other prevention methods and to multi-arm trials like the PrEPVacc trial. Our typical design I have operationalized here. That down arrow represents the period when someone is making the key visit. At the randomization period, someone comes in, is assessed for HIV, assessed for eligibility, and their willingness to participate. And at that point, they're randomized either to receive the product or not to receive the product. And any period prior to the randomization is ignored. So all HIV positive people would be excluded from such a study. This would represent the most direct evidence of the effect of a PrEP agent. However, it has good aspects and bad aspects. It's no longer an ethical way to approach our studies because one arm would be deprived of effective prevention. We get a clear sense, and by background HIV incidence, I mean the incidence of HIV in the absence of PrEP. And that's available from those who would be randomized to a non-PrEP containing arm. And since all the participants on both arms are from the same population and from the same period, we have a valid comparison of HIV incidence on a product versus not on a product. Now, one thing is that this may affect which populations would be willing to enter our study. Some may not be eligible, some may not be interested. But the beauty of this design is that the internal validity is unaffected by the population recruited. And it gives a clear assessment of the comparative effectiveness if there are two PrEP arms and a non-PrEP control. The innovation of the PrEPVacc study is that it would replace a concurrent randomized non-PrEP arm with the use of HIV incidence in a pre-PrEP period. So I represent it with this diagram. My down arrows represent 2 key visits that participants in such a registrational cohort would need to make. The first is at a time prior to the initiation of PrEP that I call minus tau 0, which begins the registrational period. People then would have to be HIV negative at the time of registrational enrollment. They would have to meet some kind of eligibility criteria, and of course, they would have to be present for that visit. The second key visit would be the point at which people would be screened and then hopefully initiate HIV PrEP. At that point, to enter that next phase, they would be HIV negative, assessed for eligibility. They would have to make that visit and they would have to consent to PrEP. What I've represented at the bottom are lambda 0 and lambda 1. Lambda 1 being the rate of HIV during the post-PrEP period. And it could potentially be compared to lambda 0, the HIV incidence in the registrational period. Now, the interesting thing about that registrational run-in is that the key people contributing to the estimate of lambda 0 would be people who become positive between minus tau 0 and time 0, and those participants would then not be eligible for the PrEP phase. So there is some, but not complete, overlap in those populations. The appeal of this run-in design is that it does not require a randomized concurrent non-PrEP control group. And it allows us to assess the effect of PrEP and no PrEP in overlapping populations. They're not completely identical populations because the HIV positive participants do not contribute to the PrEP period. And there's the possibility of dropouts between the registrational and the PrEP period. An unfortunate aspect of any design which has 2 separate time periods in which PrEP is assessed is that it's going to be susceptible to secular HIV incidence trends. So if treatment as prevention were to scale up, or PrEP in the community were to scale up, it could drive down HIV incidence and create an artificial difference between the pre and post PrEP period that doesn't represent the direct effect of the PrEP agent. It's also threatened by the possibility that people who enter the registrational cohort could test outside of the study and find they're HIV positive and no longer be willing to return for further assessments. In addition, individuals in this registrational period may choose to initiate PrEP outside of the study, which would mean that the registrational incidence would no longer represent an incidence outside of HIV pre-exposure prophylaxis. It requires a very particular setting and population. It would have to be a population at risk for HIV and therefore in need of HIV prevention. People who are open to HIV prevention in the future, since they would intend to lead into a PrEP study, but willing or maybe required to wait, either willing by choice or needing to because of a lack of availability of PrEP in their context. So as such, since it involves some periods where PrEP is made available and other periods where PrEP is not available, it seems to involve a number of ethical and operational issues that the PrEPVacc team has wrestled with. I want to now make a connection between this approach and an approach that has a lot of promise, and that is the use of HIV recency testing. So you will be hearing other talks that will describe the value of HIV recency assessment prior to the initiation of PrEP as a way of estimating HIV incidence. But what I want to point out is that this actually has a close connection to the ideas of a run-in period. In a recency design, there is a single key visit. And at that visit, individuals are assessed for their HIV status, their eligibility and willingness to initiate a PrEP product, and then they can be followed after that time if they're HIV negative and have that incidence lambda 1. However, at that time, individuals would be assessed for their HIV status, and recency assays could be used to assess up to a period in the past, which I've called minus lambda tau again. So those who were HIV infected at the screening and who recency suggests were infected prior to minus lambda tau are long positive individuals and actually not of interest. They kind of drop out. But those who show that they were HIV infected in the period minus tau 0 to 0, actually, those people, in addition to the people that screened negative for the trial, would have been individuals who would have been eligible for a registrational cohort starting at minus time 0. So it's possible to use the number of recent infections out of the total population to assess an incidence during that recency period that I've drawn here. Okay. So this is very similar, as you can see, to the registrational cohort in its spirit, not operationally, but in its spirit. It reconstructs after the fact a registrational cohort, even though it recruits individual only at a single point in time. As a matter of operationalists, we must find by opportunity an existing non-PrEP cohort. So among those individuals assessed at the screening visit, we will need to find individuals who happen to have been HIV negative at minus tau 0 and who are untested and not using PrEP in the period prior to screening for the study. That actually raises many operational issues because it requires the recruitment of a very specialized population. We would not want a population to screen for such a trial that has been heavily pre-screened. We would not want one which had been using HIV pre-exposure prophylaxis in the short period prior to the trial. In order for this method, and this is also true of the recency method, is that the efficiency of the comparison of the effect of PrEP depends on the number of HIV infections detected in the recency period, which is typically 6 to 9 months. So both in a registrational cohort and in recency design, if there are very few infections detected during the registrational period or during the recency period, then we will have very little power to detect the effect and estimate with confidence the effect of a PrEP agent. And the recency design also compares across two distinct periods. So it is also susceptible to the same secular HIV incidence trends that a registrational cohort would be susceptible to. Overall, I believe that run-in designs are a very promising way to construct a synthetic control group for the assessment of a PrEP product, because it's one that would allow for a population in which PrEP is assessed and in which we have a control group, and that control group and that PrEP group are highly overlapping, although not completely so. However, the run-in design really restricts the kinds of places and populations in which PrEP could be assessed. We need to find populations with a need for PrEP that don't have PrEP, but are open to PrEP. That would happen by design in the run-in approach, and the recency approach has to basically find a run-in group after the fact. So I hope that there'll be more interest in the use of run-in designs and also in recency designs, although they're going to present some major challenges in terms of where we do trials and what kind of populations are recruited for those trials. Thank you very much.